Good evening, everyone. Welcome to session 18 of the SCTS Foundation Doctor Academy National Teaching Programme. It's my absolute pleasure to be joined by Mr. Giovanni Mariscalco, who's Head of Service for Cardiac Surgery and the lead clinician for Complex Aortic Surgery at Glenford Hospital, who's going to be talking to us about acute aortic syndrome. Over to you, Mr. Mariscalco.
Yes, thank you very much, Hannah, for this kind presentation and invitation. So, acute aortic syndrome is a big book with a lot of important topics to be discussed. I will try this evening to be quite quick due to the extensive number of slides and provide a short summary in all the important aspects of this pathology. So, which are the learning objectives? So, we need to be able to describe the aortic anatomy, understand the pathophysiology of acute aortic syndrome, recognize the clinical presentation of patients affected by acute aortic syndrome, understand the diagnostic criteria, and describe the surgical management of patients with acute aortic syndrome. The summary of this topic. We are going to discuss briefly the definition and some interesting historical notes, the epidemiology and the anatomy, which play an important role in understanding the acute aortic syndrome, the classification, the clinical presentation and the imaging supporting a prompt diagnosis, the natural history, and the medical management and the surgical strategy behind acute aortic syndrome. And finally, we'll just briefly mention the importance of a follow-up in patients undergone repair because of acute aortic syndrome. We are not going to discuss the epidemiology section because this is another huge chapter of the book of acute aortic syndrome. I will just focusing on the acute aortic syndrome involving the thoracic aorta. Definition. So 2 weeks ago, the American guideline has been released. And if you go in the chapter 3, you will see the definition of acute aortic syndrome. Acute aortic syndrome, a life-threatening condition in which there is a breach in the integrity of the aortic wall. And this is a key definition because understanding the anatomy of the aortic wall will clarify also the type of acute aortic syndrome. Below there is a table which is quite famous, is originated by the IRAD study. And you will see that if you don't treat an acute aortic syndrome, within 72 hours, 50% of the patient unfortunately die. And 80% of them die within 2 weeks. Historical notes. So interestingly, the first population describing acute aortic syndrome were the Egyptian doctor in 3,500 years ago. This is the Ebers Papyrus, where they describe the rupture of an aneurysm, and also they describe also the attempt to treat medically this problem with fire. Of course, this was the beginning of the modern surgery. The one who described more accurate, in a more accurate way, the acute aortic syndrome, a dissection was Galenus, a Roman doctor, who analyzed several bodies of dead gladiators, and in one of them, he spotted a new disease that was aortic dissection, the rupture of the aorta. The first book who described in several paragraphs aneurysm and aortic dissection was Vesalio in his De Humani Corporis Fabrica in the 16th century. And probably on the right you recognize the King George II, was the first important person who died because of dissection. But the one who described the relation between the aneurysm and the rupture of the aorta was the French scientist Laplace with his equation. From the surgical point of view, the origin of the surgery and the repair of acute aortic syndrome is due by these two gentlemen, Michael DeBakey and then Tom Cooley in the 50s. So they reported in Germany in 53 the first successful repair of the ascending aorta through an interposition graft. Epidemiology. This is the data obtained by the NICOR registry from 2007 to 2019. You can see the blue line on the top is the number of dissections treated annually in the United Kingdom. As you can see, there is a constant increase from 2000 operation because of type A acute aortic dissection to more than 500 in 2019. And this is also valid for all the age subgroups, as you can see on the bottom, different color. Anatomical consideration. Anatomy is very important because this makes you understanding better the clinical presentation, the possible complication, and also the strategy, medically or surgical, that you need to adopt to overcome an acute aortic syndrome. I will briefly put my attention on the aortic arch when there is the origin of the supraortic vessel, the innominate artery, the left carotid artery, and the subclavian artery. And you will see later on why it's so important recognizing the anatomy in the acute aortic syndrome. This is the root and the first portion of the ascending aorta. Again, put your attention in the sinus of Valsalva and in the origin of the coronary arteries. You will see here on the left the circle of Willis, and in particular, the anterior spinal artery, which is very important because this is the first point of the vascularization in the spinal cord. You see on the right that from the aorta and from the subclavian artery, there is a strict correlation with the vascularization of the spinal cord. And this is clearly can be summarized by this beautiful picture from the grip group, will show you the strict correlation between the aorta and the spinal cord. From the anatomical point of view, we can classify the segment of the thoracic aorta in several zones. I just report on the left the most common. The zone 0 is in essence from the sinotubular junction to the origin of the innominate artery. Zone 1, between the innominate and the left carotid origin. Zone 2, between the left carotid and the origin of the left subclavian. The zone 3 is included the first 2 centimeters distally to the left subclavian, up to the 4th thoracic vertebra, and the zone 4, which is after this point. Why this is important? Because you will see in many reports nowadays in literature, but also typical operation notes, that we are going to describe now the operation or the hybrid approach, reporting exactly the zone that you have treated. This is very important as a nomenclature because it makes easy the life when you read a radiological report, or also when you read the operation notes of a colleague. Classification. In essence, we can classify the acute aortic syndrome in 2 main groups: the dissection, which is involved with the classical type A acute aortic dissection, intramural hematoma and penetrating ulcer, aneurysm. And with the term aneurysm, we don't intend the elective aneurysm, but the impending rupture of aneurysmal aorta. And there is a minority of acute aortic syndrome that are due to iatrogenic causes, traumatic, or also as a result of a pseudoaneurysm, especially following a previous open heart surgery. Anatomy is very important, especially the understanding of the aortic wall layers is the key to understand and comprehend fully the acute aortic syndrome. The adventitia, the external layer, the media, and the intima. Just bring your focus in the so-called vasa vasorum. This is the typical histopathological feature of a dissection. On the left, you will see dissection occurring in a bicuspid disease, in a Marfan disease, and in a atherosclerotic aorta. You will see that there are a common feature, the separation between the adventitia with the intima. And on the right, you will see the key role of the vasa vasorum in patients with dissection of the vasa vasorum are occluded and necrotic. Therefore, based on the involvement of the aortic layer, we can recognize different entities. Aortic dissection which a clear separation between the intima and the media with a tear and a flap. The intramural hematoma, when in essence you have part of the aortic wall who has an hematoma. The penetrating ulcer is a sort of focal rupture. An aortic pseudoaneurysm, again, there is an involvement of only a limited portion of the aorta. In essence, the aortic wall is just very thin, and the traumatic aortic injury when there is a full rupture of the aortic wall. But 90% of the acute aortic syndrome can be represented by the typical or the classical aortic dissection, the intramural hematoma, and the penetrating aortic ulcer. It's very interesting because in the last decades, there's been a big debate in order to understand if these three acute aortic syndrome are different or they belong to the same disease captured in different time frame. This is a study published in 2012 by the Japanese group of Ueda and colleague. And you see that in this theory, the classical dissection in terms of pathophysiology is different from the intramural hematoma and the penetrating aortic ulcer, and also with the aneurysm. You will see that the classical dissection is due to a degeneration of the media. The penetrating ulcer is due to atherosclerotic process of the intima. And the aneurysm with an impending rupture of the pathophysiology is related to a degeneration of the entire aortic wall due to the aging process. But Sand, and this is coming from a surgeon perspective, consider the intramural hematoma, the penetrating ulcer, just disease that precede the classical aortic dissection. You will see that it seems from this theory that penetrating ulcer is the beginning of the process, which lead to an intramural hematoma, and both of them, they lead to a classic dissection, and the final outcome is the aortic rupture. Based then on this theory, we can recognize, based on the severity, a new classification, which has been published in 2014 in the European guidelines. You have the class 1, which in essence the classical type A acute aortic dissection. The class 2, the intramural hematoma. The class T is an aortic dissection with the bulging of a limited portion of the aorta. Class 4 is the penetrating aortic ulcer, and class 5 is the iatrogenic or traumatic aortic dissection. We see here a catheter-induced dissection. This is the classical classification that I'm sure every one of you knows. So we have the Baker classification, type 1, when the full aorta is involved, type 2, only the ascending aorta, and type 3, after the origin of the subclavian artery, and the Stanford type A and type B. But probably this is the most recent classification, the most precise. As you can see, it's called TEM, aortic dissection classification. This classification is going to tell you the type of the dissection, type A and the classical type B, but is also identifying a new entity which is called non-A, non-B dissection. This normally is defined by acute aortic syndrome originating with an intramural hematoma after the subclavian artery that is extending retrogradely into the aortic arch. And probably this is the most accurate classification available. Clinical presentation. Acute aortic syndrome are characterized by chest pain, in 80% of the cases, a back pain with interscapular pain, which is more common in the type B acute aortic dissection in comparison with type A. The pain is characterized by an abrupt onset, but only in a minority of cases this is a migrating pain. And of course, there are specific signs, which again are strictly related to the anatomy of the aorta. This sign can be asymmetric blood pressure, for example, when there is a partial occlusion of the subclavian artery, bowel ischemia, when there is an involvement of the mesenteric artery or the celiac trunk. And another sign that is very important is myocardial ischemia, often patients with myocardial ischemia are confounded with patients affected by coronary artery disease. Signs are the same, treatment is completely different. And also the sudden onset of aortic murmur due to the aortic regurgitation, because the dissection is creating prolapse of the non-coronary sinus and the non-coronary cusp. This is the three mechanisms that are leading to the clinical sign that I just described. There is a static mechanism. This, in essence, happens when the false lumen is compressing the true lumen constantly, and there is the initial formation of a thrombus. The dynamic is when the false lumen in systole and diastole is compressing and occluding with intermittent feature the lumen of a branch of the aorta, or the static and dynamic mechanism when both the previous mechanisms coexist. Obviously, in order to make a prompt diagnosis, when you know that the patient is affected by some condition, like for example, a Marfan syndrome or a family history of aortic dissection, with association in the typical clinical presentation just described, so abrupt onset of the pain, interscapular pain, and also some typical clinical sign, you are in the position to suspect an acute aortic syndrome. And of course, the prompt recognition of an aortic syndrome and a prompt diagnosis make the difference in terms of survival for the patient. You see here that when the diagnosis occurs after 8 hours, the mortality increases exponentially. Diagnosis. There are not much to say about a laboratory test. There are some papers who show correlation between dissection and edema, unless this has not been proved in a solid way. Chest X-ray can be very useful, and often doctors, they don't put much attention on the chest X-ray. So this is a patient that has been treated in Glenfield 2 weeks ago. Was a patient admitted at the beginning of November in the cardiological unit. No one put much attention on the chest X-ray. And this patient, only 6 days later, was diagnosed with type A acute aortic dissection. Of course, the two gold standard in terms of imaging is the transthoracic echo and the CT scan. The reason is because they are generally available, very quick to perform. They allow you to have a quick acquisition of imaging and a lot of details. On the left, you will see a typical feature of a type A acute aortic dissection diagnosed through a transthoracic echo. You will see the flap, the prolapse of the non-coronary cusp here. And on the right, you see the typical feature of the CT scan of a type A acute aortic dissection. The true lumen on the right, the false lumen on the left, and also in the descending aorta, a rim of intramural hematoma. Obviously, all the time you perform an imaging investigation, like a CT scan or transthoracic echo, there are important information that you need to retrieve. In order to confirm the aortic dissection, you need to identify the intimal flap, the true and the false lumen, and so on. And of course, the CT scan is very important because also you can confirm the suspicions of malperfusion. And there are other important features also in the intramural hematoma and the penetrating aortic ulcer. So these are the most important characteristics that normally you need to retrieve, especially diameter is very important nowadays with the frozen elephant trunk technique. This technique allowed you to put in antegrade way a stent. Because of that, you need to know exactly the anatomy of the aorta and the diameter of the true lumen or the diameter of the entire aorta to size correctly the stent. You can see here the typical imaging feature of an acute aortic syndrome. On the left, you will see a type A acute aortic dissection. You see the full dissection arising from the aortic root, involving the aortic arch, the full thoracic aorta. On top right, you will see a penetrating ulcer, the intramural hematoma, with the hematoma compressing partially the lumen of the aorta. And this is a typical impending rupture contained by the sternum. If you go to the guidelines recommendation, the CT scan is definitely recommended as gold standard, but also in some instances, especially if you don't need to do a prompt and emergent surgery, MRI and transesophageal echo can play a role. But we need to be careful, because if the CT scan is not done properly, for example, is not gated, you can have some artifacts, and sometimes they can lead to a mixed diagnosis of acute aortic syndrome when the aortic syndrome there isn't. Management. Why the management is so important? Because if you see the recent data, these are coming from the Harvard study, it's evident that an untreated type A acute aortic dissection is associated with death. And there is a big difference between an untreated type A acute aortic dissection, you see on the top, treated medically, in comparison with surgery. There is a much difference. This again is taken by the Harvard study. It's important that between the presentation of the patient and diagnosis and surgery, this does not exceed the 24 hours. And obviously, the timing of surgery is also related to the severity of the stage of the acute aortic syndrome. From grade 1, grade 2, and grade 3 and grade 4, you can plan an urgent operation. Grade 4 is definitely an emergent operation. Again, if you don't treat type A acute aortic dissection, 80% of the patients are dead within 2 weeks. Medical therapy. These are the recent guidelines published 2 weeks ago by these are the American guidelines. Of course, they recommend as a first management line controlling the pressure with adequate medical therapy. And the pressure normally should stay below 120 millimeter mercury systolic pressure. What about the guidelines for the surgical treatment? The guidelines slightly differ between the acute aortic syndrome type. While in the type A acute aortic dissection, emergency is always recommended. In case of intramural hematoma and penetrating ulcer, normally they recommend an urgent planning, not an emergent operation. However, also in type A acute aortic dissection, we need to take into consideration the concept of malperfusion. We have saw before, there are typical signs which are a typical example of malperfusion. Hello? Can you hear me?
Yes, Mr. Mariscalco, I think someone was accidentally unmuted. Don't worry.
Okay, sorry, apologies. I thought that the connection was not good. So, yeah, malperfusion is a key role, and there are typical signs of malperfusion. At the cardiac level, you can have myocardial infarction. At the cerebral level, you have patient with a stroke, paraplegia, TIA. The mesenteric level, you can have a patient with bowel ischemia. And also, this is a very typical feature. Sometimes you can have patient with ischemia localized in the leg. So when there is a type A acute aortic dissection malperfusion, as you can see, this is the flow chart of the American guidelines. Everything becomes more complex. More complex, we can summarize simply, saying that when there is a rupture and tamponade and stroke, surgery is always recommended. When you have malperfusion, especially at the bowel level or lower extremity, it's important a strong debate with the vascular colleague to understand if it's wise to fix first the malperfusion, especially when it's involving the bowel or the liver, or carry on directly with surgery. In this case, you can do surgery with a more sophisticated approach, repairing at the same time the aortic arch and the descending aorta, or you can just focus your attention on the proximal aortic arch, leaving to the vascular surgeon the final treatment with endoprosthesis or fenestration. Intramural hematoma, as I just mentioned before, differently from type A acute aortic dissection, require an urgent repair. This means that you can plan the operation quite accurately. Of course, if there is a concomitant sign of malperfusion, periaortic hematoma, or already pericardial effusion, surgery cannot be delayed. The penetrating ulcer, the same, allowed you to plan surgery properly, and you can do an urgent operation. When there is the concomitant penetrating ulcer, intramural hematoma, again, an urgent surgery is recommended. Surgical consideration. If you see the guidelines, this is referring especially for type A acute aortic dissection. What they recommend is to fix the problem, which normally is located in the ascending aorta, in the proximal part of the aortic arch. Of course, surgical technique can vary depending on the extent and the severity of the dissection or the aortic rupture. What is important is that it's not the technique that is the most important part of surgery, but the technique that needs to be related to the patient status. It's obvious that if you have an old patient with sign of malperfusion, doing a very sophisticated and prolonged operation is not wise, probably just to fix the acute phase, relying on the vascular support. And obviously, you can see here the concept of acute aortic syndrome that for the first time stressed in the guidelines is the relevance of the aortic multidisciplinary team. So decision is not only based by surgeon wish, but also is based on anesthesiological, intensivist, vascular, radiological support and discussion in order to achieve the best goal, which is the survival of the patient. And relating to this concept of the aortic multidisciplinary team, what is important is that normally, also like for other kind of surgery like AAA or bypass, there is a clear relationship between volume and outcome. You can see here, this study has been published in 2013, a decade ago, which showed that the best results are achieving centers that performing at least 70 major aortic procedures on a yearly basis. This is a study by Professor Wu, which showed that normally you achieve the best outcome when you perform more than 5 type A acute aortic dissection operations on a yearly basis. This is a meta-analysis that my group did some years ago, which show clearly that the benefit in terms of better survival are evident not only in high volume surgeon, but also when you discuss about high volume surgeon. Of course, the technique to repair the ascending aorta and the aortic root are the standard one. You see the typical technique of sparing operation, Bental operation, or just a simple aortic valve repair and interposition graft. What changed in the acute aortic syndrome is that in order to achieve a successful operation, you need to deal at least, I repeat, with the proximal part of the aortic arch. This is the difference between acute aortic syndrome and aneurysm of the thoracic aorta. The problem is, all the time you approach the aortic arch of the descending aorta, there are important topics that needs to be analyzed and discussed. The organ protection, the concept of hypothermia, the cannulation site, how to deal with the cerebral protection and perfusion, and also the new concept of the hybrid approach. Why? Because if you see the data, again, taken by NICOR and AXA data, the hospital mortality when you do arch surgery is approaching 12%. This includes emergent and elective operation. While when your operation is just focused on the aortic root on an emergent or an elective basis, the mortality is only 4%. Cannulation strategy. The guidelines clearly recommend, in case of acute aortic syndrome, the cannulation of the axillary artery in comparison to the femoral artery. While the venous cannulation is standard, you can use dual stage with the cannulation of the right atrium or the vein femoral cannulation. In terms of arterial cannulation, the discussion is a little bit more complex. The recommended by the guidelines is the axillary artery. I will also add the innominate artery. Another site of cannulation is the femoral, or now some group perform a direct cannulation of the aorta under TOE guidance. What is the difference? That all the time you do an antegrade arterial perfusion, in this case axillary, versus femoral artery, you see the big difference in terms of mortality, renal failure, bowel ischemia, bleeding, external infection. So there is no doubt that the axillary artery or the innominate artery perfusion provide bigger benefit than the femoral perfusion strategy. Why it's important? Because we need to understand that in order to perform such a surgery with involvement of the aortic arch and descending aorta, we need to protect the brain to avoid the stroke, TIA, paraplegia, heart, the kidney, and also the bowel and the liver. In order to do this, since the 60s, the hypothermia concept was introduced. It's a very simple concept. This is the classification between mild hypothermia, moderate, deep, and profound hypothermia. And the concept is that while you cool in the body temperature, the oxygen consumption is also reduced. This is the famous picture from Kirkland, published in 93, which show that with the reduction of the temperature, the cerebral oxygen consumption logarithmically is reducing, which means that more you cool the body, more you protect the brain. However, hypothermia is not exempt from side effects. Hypothermia have important effects at cellular level and also systemic effects. It's affecting, for example, the gut bacteria. In favor of the gut bacterial translocation is affecting the hematoencephalic barrier. And this is the reason why in the last decades has been a big debate between hypothermia and mild hypothermia or normothermia. So there are two complete different schools of thinking. The same principle between hypothermia and perfusion is also applying when you need to remove, detach the supraortic vessel. So there are two strategies. The deep hypothermic circulatory arrest, in essence, you cool down the body of the patient, you don't do any perfusion to the brain and to the rest of the body, or new school that arose 20 years ago with the perfusion, antegrade or retrograde perfusion of the brain and the organs. The deep hypothermic circulatory arrest is still used in many centers. In essence, you cool down the body normally to 18 degrees, and this allowed you to have 30, 35, 40 minutes of safety in order to avoid major damage to the brain. You see, this is a study that took into consideration the cognitive impairment of the patient following the operation. You can see that already after 15 minutes of deep hypothermic circulatory arrest, we have some mild degree of impairment. A study by the Lefteriades group, which clearly showed that when you go above 50 minutes of deep hypothermic circulatory arrest, the stroke rate is massive, approaching 20%. In order to limit this risk, the antegrade cerebral perfusion has been introduced. We have an example here, unilateral. In this case, after the cannulation of the axillary artery and clamping the innominate artery, the left carotid, left subclavian, you can perfuse the brain to the right carotid artery. Bilateral, when you perfuse the brain again through the axillary artery, through the right carotid artery, but also introducing a selective cannula into the left carotid, you perfuse also the left side of the brain. There is another way to perfuse the brain. This is called retrograde cerebral perfusion. Instead of going to the artery side, you go from the superior vena cava and you invert the flow. However, there is, in the last year, there is a new kind of cerebral perfusion, which in my view is the most complete one, which is the trilateral antegrade cerebral perfusion. So in essence, you perfuse the carotid arteries, but also the left subclavian artery. The left subclavian artery, if you remember from the first slide, is very important because it allowed you to maintain a perfect cerebral perfusion also in the posterior part of the circle of Willis, and also to the vertebral artery and to the anterior cerebral artery, to the anterior spinal artery. So in essence, providing a good perfusion, at least of the first portion of the spinal cord. Why it is important, this trilateral antegrade cerebral perfusion? Because there is a big portion of the population in which the circle of Willis is incomplete. which means that if you do only unilateral cerebral perfusion, you are not sure to protect fully the entire brain and also the spinal cord. What the literature evidence is? Literature clearly demonstrates that in terms of stroke, antegrade cerebral perfusion and retrograde cerebral perfusion are superior to deep hypothermic circulatory arrest. This is also valid in terms of post-operative mortality. No difference between a retrograde and antegrade cerebral perfusion. Therefore, both the techniques are really good, and you need also to take into consideration the anatomy of the patient when you select between antegrade and cerebral perfusion. The typical example is when you have a patient with a full dissection of the aortic arch, with a dissection of the innominate artery in the left carotid artery and the left subclavian artery simultaneously. So as you can understand, in this case, it's not say place or manipulate the carotid arteries. In this case, the retrograde cerebral perfusion can be of help. Also, antegrade cerebral perfusion can present some major problem. If you push the cannula too high, the risk is that you're going to push the cannula into the right subclavian artery, perfusing the arm instead of the brain. And also, if you have an old patient with highly suspicious for atherosclerotic disease in the carotid artery, you can create embolic dislodgement. Or sometimes, if the pressure of the perfusion is too high, you can create a iatrogenic dissection. Again, we have discussed about cerebral perfusion, but also there is a technique that is allowing you to protect the distal body. You put a point cannula or a Foley catheter into the descending aorta, you flush the balloon, so occlude the vessel, and you can perfuse from this line, maintaining a decent blood perfusion of the bowel, the liver, the kidney, and the leg. Again, it's not the technique, but it's the patient that it should drive you to the best surgical strategy. We have discussed about the hemi-arch. When you need to replace the full arch, you have two different techniques. This is called the branching. As you can see, this is the loopy prosthesis. You have several branches for which you're going to detach and attach the branches to the innominate artery, to the left carotid, to the left subclavian. This allowed you to create a so-called landing zone for a possible subsequent full reconstruction of the descending aorta through a stent. Another procedure that has become very popular in the recent year is the so-called frozen elephant trunk. The concept is the same. You replace the full aortic arch. You are going to detach the supraaortic vessel and implant in each of these branches. But at the same time, this device is attached to a stent that you can deliver into the descending thoracic aorta. And this is the full reconstruction, which is very good, especially when you have a tear distally into the aortic arch, even at the level of the subclavian artery, because this makes your life in surgical terms very easy. You can fix everything in one single go. Of course, this procedure is to be done by experienced center, and it's quite demanding in terms of timing and the entity of the operation itself. Again, when you replace the aortic arch and there is a sign of malperfusion, you can fix this in one single stage or in two stages. In both cases, the hybrid approach is the key of the success. Outcomes. This is the data again published by our group in 2021. We take into consideration more than 10 years of experience in the United Kingdom. You see that in around 2009, the mortality following type A acute aortic dissection was 23%, and it went down slowly to 15% in 2019. So there is an improvement, definitely. Again, the same paper, we show interesting evidence. So this is an evaluation of the outcome following the repair of type A acute aortic dissection, and this is divided by center. You can see here on the top the number of dissections performed by low volume, medium volume, and high volume center. There is a clear difference between the high volume center. The mortality is 14% against 18 and 19, is significant in terms of stroke, in terms of post-operative dialysis, and also exploration for bleeding. If you analyze the same data, this time for the surgeon volume, you see in the top, surgeon performing from 1-3 dissection on a yearly basis, 3-5 and more than 5. You see again that there is a big difference in mortality, 13% against 20%. No difference for the other outcome. Well, because these outcomes in terms of stroke, postoperative dialysis are more related to the experience of the center and the intensive care unit in dealing with complex patients. And of course, the younger is the patient, the better is the outcome. Follow-up. So what is happening when the patient is discharged? The recent American guidelines finally summarize for the first time a clear pathway. So when the patient is operated on, CT scan or MRI needs to be performed after 1 month, which is your basal point, 6 months, 12 months, and everything is okay annually thereafter. The problem is when there is a residual dilatation of the aorta, and when these exceed 5.5 centimeters, a reoperation is recommended. These are the references. This is the study just mentioned, the American guidelines published in the Journal of American College in November. Herbel are the European guidelines, and these are interesting studies describing the anatomy and the surgical techniques and the anatomical history of dissection. Thank you very much for your patience and attention.